Hello and welcome to the Weatherford College EMS podcast. This is episode 4, where we're going to be talking about vasopressors today. This is where education meets experience and textbooks meet the street. I'm your host, Tyler Holland, also known as the NIH Man. I'm joined here with our resident EMS historian, Adam Parrish, and the been there, done that career guru, Samantha Grimsley. We're going to be kicking it off with a crucial chapter for our second semester paramedic students, Pharmacology. And this isn't just drug names and dosages. This is about critical thinking, patient impact, and why what you give matters. We're here to break it down, keep it real, and maybe even have a little fun with it. So, Sam, how about you kick it off?
Yeah, I feel like this is the nerd section of your guys' topics of all things. I'm just here to facilitate, I feel like. But we're going to start off with epinephrine, because we talked a lot about epinephrine, and vasopressors is like Adam's go-to thing that he loves, but
so much.
We've talked about epinephrine in so many different ways now. Like we've really hit home on it. Now let's talk about it from a vasopressor standpoint. So why is it in this list of vasopressors? Where does it fall in line with, you get a lot of patients who are like, or people are treating these patients and they're going, how do I choose? How do I choose dopamine? How do I choose epi? How do I choose levo? What is the choice? How do I make that connection? What do I do?
And this very question is exactly why this topic gets a lot of people. You must know how this stuff works. You must be able to choose the correct vasopressor for your patient based on what is happening to them and why. When we start getting into it and we start talking about epi, everybody's got epi. There's epi on every single ambulance out there, or ALS ambulance rather. It's widely available, widely used. We talked about it for use in cardiac arrest and how it works and what it does. But essentially what we're going to talk about in terms of vasopressor, remember the discussion for cardiac arrest when I was saying that it's really kind of counterintuitive to, bring everything down It's really counterintuitive to vasopress everything down against a sick heart. Well, that's exactly what we want to happen when we start talking about a vasopressor and trying to raise up that blood pressure when we want to give epi. Now, the concern is, we all know that in an alive patient, because of all those alpha-1 effects, we're going to start seeing a raise in heart rate. Right. We're also potentially going to see, what we want to see is also the raise in blood pressure for two reasons. One, right, we have our alpha-1 effect, so we're going to raise the ability for it to squeeze harder. It's going to increase the chronotropy, the dronotropy, and the inotropy. All of them increase with epi. This will then not just, squeeze down on everything and vasoconstrict, right? But it's also going to raise up your cardiac output. And as such, we know that heart rate times stroke volume equals cardiac output. If we're going to increase that, then we're going to see a higher blood pressure. The issue, though, is how high is that heart rate going to go? How high is the heart rate already? Because as we know, we talk about hypotension, and one of the big things that the body likes to do to compensate is to raise the heart rate.
Yeah.
So we have to be very careful when we start talking about epinephrine as a vasopressor to somebody that already has a super high heart rate.
Yeah, so that's where it comes in. How do we pick which vasopressor to give? I love catecholamines, and I just love to say the name catecholamines. But we also know that these are sympathomimetics, right? There's going to be quite a few different names of these medications that you might hear get thrown around, and it's important to, just like with the dihydropyridines and non-dihydropyridines, is to know all the different names that these could be called. But whenever it comes down to choosing which one we want to give, we got to look at those factors. Is the heart rate compensating? If it is, okay, well, maybe want to try something else. If it's not, number one, why? And number two, they probably need epinephrine, right? So figure out through a good patient assessment what factors could be leading to a poor compensatory mechanism, right? Because we don't want to add insult to injury.
Yeah, and there's also some things that we need to consider, kind of like Tyler was talking about. If we have somebody with a heart rate in the 30s and they're hypotensive and we're going to pace them, and it's not quite doing exactly what we want, but we have the rate where we want, and there's not a whole lot more that we're going to do even if we increase the rate. You can only do that so much up to a certain point. I mean, this is still a sick heart. You don't want to take somebody that has a heart rate of 30 something and then pace them at 100. Like that's not going to do it. Mm-mm. Right? So eventually, once we start looking at anything above like 80-ish on the rate for pacing, we really need to start thinking about putting something on top of that. And something like epinephrine would be perfect for that situation, because it's going to it's going to work with the pacing. It's going to help try to prime the heart for increasing its own rate. And then we can maybe even back off on a little bit of that electricity if it starts working well. So, but because it has all of those other factors associated with it, it's really going to help that heart be able to not just increase in rate, but also like increase the squeeze. Mm-hmm. That's a big part of it. And that's a big part of why epi works really well in those types of patients.
Mm-hmm. So the thing I really love about epinephrine is how versatile it is. You've got 1-to-1 that comes in your little ampule. You've got your cardiac epinephrine, your 1 to 10,000. But you could also make this into, you could further break it down into a 1 in 100,000 epinephrine. You just take a squirt of this, 1 ml of this, get your 10 ml flush, take out 1 ml, pull up 1 ml, mix it up, and then for every ml, you've got 10 mics of epinephrine that you could give push dose. So if you don't have time to spike that bag of epinephrine, this will be a little bit quicker to give your patient that little boost that they need. And you give that every 3 to 5 minutes to help facilitate a better blood pressure and heart rate, giving you time to set up a vasopressor, whether it be epinephrine or whatever else you might choose. And it also gives you the benefit of seeing the heart's reaction to the epinephrine. Well, maybe we shouldn't give epinephrine infusion to this patient because that push dose sent them a little bit too high on that heart rate.
Yeah, it's more of a Band-Aid situation where it is so easy and it's so quick, and you can give them just little bumps along the way until you can have whatever loaded up that you need loaded up. It's very effective, but you have to be pretty careful with it. You don't want to sit there and all of a sudden hit a bump and give like 50 mics at one time. Like, right. That's not what we're trying to do. Generally, it's about 1, maybe 2, I'd say mics, 1, maybe 2 milliliters a time for every dose. So really no more than like 20 mics at a time. Right. And you want to give it a couple of minutes in between before you give the next one, because remember, like, it also depending on your access and everything else on how quickly the stuff is going to work.
Yeah.
Now, if you're trying to get from A to B, this is a fantastic way to go with your push dose. Just know that, we are taught, you don't want to take a cardiac epi, a 1-to-1, and then take 1 mil out of that cardiac epi and put it in a syringe and start giving them bumps like that, because now you've doubled the dose.
Right.
And that's way too much. Okay, essentially what you've done is just created cardiac epi.
Exactly. Yeah.
And so you have to be very mindful that what we're talking about is taking the cardiac epi, the 1 to 10, and then diluting that even further.
Yeah. I know earlier we were talking about making your own 1 to 10,000. Now we're talking completely other end of the spectrum. Instead of taking the 1-to-1 and making a 1 to 10,000, we're taking the 1 to 10,000 and making a 1 to 100,000.
Exactly.
Such a weird number,
You
but
keep on breaking it down to what you need.
You did say earlier, it's a versatile drug, and that's 100% correct because we use it in so many different ways, from anaphylaxis and talking about anaphylactic shock to cardiogenic to septic. It's used, and even in respiratory patients, nonetheless. But it's used so much because of its versatility. And I know we talked about alpha 1 and beta 1. It has beta 2 principles as well, allowing for that bronchodilation. But realistically, what are some risks of repeating this medication over time? Arrhythmias obviously would be a big one, especially. What about O2 demand on the heart?
Absolutely.
Ask for more.
You're going to see a lot of the negative side effects with this drug. And where I really advocate for it is that it's going to do a good job of keeping that heart pumping. But those negative side effects, like the myocardial oxygen demand, and one of the really big things is going to be that peripheral vasoconstriction. So these patients that, and it's another one of those things that we don't see in the pre-hospital setting, but you're going to see it in the hospital. These patients that are on vasopressors for very long periods of times, they're going to be losing their fingers, their toes, and it's going to work its way up where that vasoconstriction is, and you're going to be losing limbs and potentially organs because we need this pressor to stay alive, but it's also, it comes to a point of life over limb, right? And it does a great job at it, but there are some pretty harsh side effects over long periods of time. Your short-term little bumps of push-dose epinephrine, you're not going to see those big effects, but when they start to get on that infusion, that's where you're going to start seeing the potential for cardiac dysrhythmias and increased myocardial oxygen demand. You might see some very broad ST elevation in all the leads. Maybe they're starting to get a little bit ischemic too.
Yeah. It's probably why it's not called your first line of vasopressors. It's more your second line in an essence.
Yeah, not typically going to be your first line, right? It can be a first line in some very specific ways, kind of like I was talking about. You have your bradycardic hypotensive type patients, fantastic. You would probably want to use it for that because of those alpha 1 effects that you're going to get. However, for just somebody that is just sick and hypotensive,
no,
not the way to go.
Yeah, so let's change the script for a second and go over to what the first line medication would be. And I think it's ironic because the phrase used to be leave a fed, leave them dead. Mm-hmm. And that comes from a time where norepinephrine was considered the last ditch vasopressor because it had such a poor survival rate. It was like, let's just throw it at them and see if it's going to work. They're already down the tube. Well, let's give it another go, right? But medical practice has evolved over time. And today we're seeing norepinephrine actually being the first line of agent, especially in our septic shock patients and our other hypertensive emergencies. It's backed by a lot of strong evidence and guidelines, which brings us to why things are constantly changing. So from leave a fed, leave them dead, maybe it's leave a fed, first line, not flat line in essence.
Yeah, absolutely. Very well said.
Yeah, norepi, this one's my favorite. I love
it
norepi.
Works. It's great.
Yep.
It's fantastic. So one of its big things is, as we all know, that when the body compensates for low blood pressure, it likes to raise the heart rate. Okay, if we're talking heart rates that are above 120 or more, we really need to be very careful with epinephrine use, because that has the very distinct possibility and probability is more like it, that it's going to keep raising up that heart rate, and eventually you're going to see diminishing returns on that. It's going to go too fast. It could create an arrhythmia, all these things. But guess what? There's a fix. It's called norepi. Mm-hmm. Okay, Levophed. Levophed is not going to have all of those effects. It's not going to raise the heart rate so much. You're still going to have a lot of your vasoconstrictive properties, but you're going to not have so much cardiac involvement in terms of the chronotropy. Now, it's still going to help out with your inotropy and your dromotropy, but not so much in raising the heart rate to an unacceptable level. And one of the things is that, we know that norepi is a neurotransmitter, right? We know that this is what is going to control the sympathetic nervous system. Mm-hmm. And so we also know that, when we start giving something that is going to stimulate the sympathetic nervous system, we already should know kind of what all that's going to entail, right? Yep. The fight or flight. It's going to make us get up and go. The thing is, there's always a drawback to everything. Mm-hmm. Once you have norepi going, and we're giving what essentially is stimulating the sympathetic nervous system, it can run away on you a little bit. The nice thing, though, is, again, it has a very short half-life. So
it has the magic word,
titrate
right. To effect.
Titrate to effect. And if it's too much, stop it.
So what is the threshold then for titration? What's the magic number when we're talking systolic blood pressure, or maybe it's MAP? What are we looking at here?
You're looking for a MAP. Really, MAP is the big one.
Yeah.
Honestly, because we can all say, oh, this-ish or whatever. Honestly, MAP between a 60 and 65, that's what's really going to get you going. That's what's going to perfuse all your organs. That's going to make your kidneys happy, right? That's what's going to fix a lot of different things. So as we look at it, it's not even so much like, is it 90, is it 100, is it 92, is it 93 and a half, right? We're really looking to improve the MAP.
Yeah. One of the things that we talk about is that whole titration to effect, right? When I like is when you're talking about what you're going to give, because there are dosages that are a little bit of everywhere, right? We see 2 to 4 micrograms per minute. Nice thing is it's not a kilograms, so you don't have to deal with that aspect. But I always joke around with the students when I'm talking about med math. It's like, if you do the equation of the concentration will always come out to be 16 micrograms. And then when you talk about dopamine, it's always going to be 1600 micrograms. I can appreciate somebody giving us the number 16 in there somewhere, right? But it's good to know that across the board, whether you're doing, the 4 into, 250 or...
Right. I know it's 8 and
500 and then 4 and 250. Yes, it's always going to equal out to 0.016 milligrams. Convert that into micrograms because we're talking micrograms per minute. 16 micrograms is always going to be your concentration. Mm-hmm. So I can appreciate something like that. Now, with that being said, what are some safety signs that we got to be looking at? You mentioned the kidneys. I'm assuming we're going to see some increase in urinary output because we know in shock, and we're talking specifically like hypovolemic or septic shock, kidney perfusion is going to go down. So I would assume if things are working great, we're going to see that MAP increase. We're going to see the kidneys start perfusing. We're seeing implementation, hopefully.
Yeah.
Do we just stop it cold turkey?
No, you most definitely don't.
That's good.
This is the thing that is working. Like if it's working, we don't need we don't need to fix it. The thing that we need to be aware of though is that MAP. We don't need to raise it too much. We don't need to be playing with it too terribly much. We need to find that, like I said, 60 to 65 range is perfect. But again, that's still the low end.
Yep.
Okay, it can be brought up a little bit higher than that. But again, we don't really want it to be. We don't want to be manipulating all of these things that's happening without having a complete understanding of what's happening and why. And we're never going to have that until we start running labs in the back.
Yeah.
And I think that the biggest reason, right, is because if you continue to go up with that norepinephrine or whatever vasopressor that you have, and you start clamping down on those vessels that lead to your kidneys, you're not perfusing your kidneys now. So if we want to get the blood pressure to 120 over 80 when it was 50 over nothing, and you're bringing it up and you surpass your MAP goal, trying to go up to a normal blood pressure, you could be clamping down too much on them kidneys now, leading to other issues. And kind of segueing over into something else I was going to talk about with norepinephrine is that there's studies that show that it does have a little bit of alpha-1 properties with it. It can result in reflex bradycardia due to the vasoconstriction affecting the baroreceptor reflex. And it's generally not compensated by its beta 1 properties. So you could see a slight reduction in heart rate when you're giving the norepinephrine as well.
So on the transition of things, it's still out there for medications, and I would call it our third line drug, honestly. Dopamine. I mean, the problem with dopamine, and I even remember this from when I went to school, there's 3 different kinds of ways to utilize it. You've got your renal vasodilation, you've got your beta effects, and you've got your alpha effects, and obviously the higher up you go in medications of micrograms per kilograms per minute, the more you're looking for that push on the alpha side. And so when do you use dopamine in the situation with a patient over epi and norepinephrine?
So dopamine's still an excellent drug. But one of the things that dopamine does is it requires the kidneys to work, right? It's a big thing there, and so it won't start doing what it needs to do unless you have those intact kidneys. So we must know that, hey, 1, they're not a dialysis patient. 2, their blood pressure hasn't been low enough or high enough to where the kidneys aren't working. We have to know a few extra things for dopamine. Now, dopamine can be extraordinarily effective whenever you start having that hypotensive bradycardic type patient. Now, whereas epi really helps directly with that alpha 1, dopamine, though, if you give it, especially when you're looking at the 5 to 10 mics per kilo per minute, you're going to have that higher heart rate and greater contractility. This is how dopamine would really help that patient.
Yeah. Something I'm reading here is while dopamine and epinephrine could be very similar in how they work, right? Dopamine kind of wins out a little bit because it doesn't increase the myocardial oxygen demand as much as epinephrine or isoproterenol does.
So with dopamine, what are some side effects that we need to be watching for? Because one of the things you notice when we're talking about Levophed is the potential for, necrosis and injury if we were to lose our IV site. And we know we're infusing, so we have to make sure we have good access. It can't be, your little 24 in the hand, trying to just get anything you can. We have to have a strong access point. What do we do if we look down and all of a sudden that's not the case anymore? Is there anything? I mean, we know with dextrose we've got to continuously be checking that, but what about in these infusions where we're just putting them on the pump and walking away? Mm-hmm. What's some options that we have here?
So with almost any medication infiltration, you do want to be very cautious, and that's something that you definitely want to let the hospital know about if you don't know yourself, because these catecholamines could cause a lot of local vasoconstriction. You could lead to some localized tissue death, right? Mm-hmm. So you want to be consistently monitoring these IV sites. Just because your IV was patent when you first placed it does not mean it'll remain patent. There's a lot of factors that go into that, the patient's vasculature in general. So be very diligent when you're assessing these things, and certainly let the hospital know, hey, I was giving this medication through this line that appears infiltrated, so they could get the appropriate treatments on board as well. You might not think, you might still be in the mindset of life over limb, and while that is true, we do want to make sure that we don't have to amputate a patient's arm because you put 100 mics of epinephrine or norepi or what have you into that tissue.
You know, it's interesting enough, we're talking about dopamine, and when I started in EMS, dobutamine was still something we talked about, and I'm looking at the 2023 status from American Heart Association, and they're starting to talk about dobutamine again. We don't talk about it too much in this program. Do you guys have any insights on that you would like to provide?
Well, dobutamine really was kind of the option for your hypotensive CHF patients. That's really where it shined well. The biggest problem, though, was, I mean, typically what we're dealing with is a hypertensive CHF patient. And so it was a very, in terms of pre-hospital anyway, not something that happened super often. I mean, it still happens. And if, you know, and then again, we have these other two options where we can affect the rate if the rate's a problem, and we can affect the pressure if it's a pressure problem through vasoconstriction, right? With our epinephrine and our norepinephrine. And so, and as well as, you know, again, dopamine's still hanging on, and it's still around, it's still a good drug. But, you know, dopamine also has some drawbacks and everything. Dobutamine, though, I guess it's coming back, or maybe talked about being a thing again, as we typically move on by doing these studies, and we learn more about it and everything, and everything's evidence-based now. Well, I say everything. A lot of things are evidence-based now. We're trying to get that way anyway. And so I have limited experience with it. We used to carry it, but we don't anymore because, again, we found that those instances of hypotensive CHF patients were far and few between, and if they were still managed effectively on the pre-hospital side, usually by norepi.
Yeah.
Yeah, it's talking about more on the cardiogenic shock side with STEMI patients who have low output is where they're kind of talking about utilization of it, more or less, of course, in the ICU setting. So, you know, from a pre-hospital standpoint, maybe not going to see it anytime soon, but, you know, there is still talk of it happening out there in the field. It hasn't completely vanished quite yet. But yeah, you know, there's still some old traits that are coming back around. You know, I think the biggest thing when we talk about dopamine, the dosaging alone can be very conflicted if you don't know what you're doing, and I think it always comes back to the whole titrate to effect. Start low and titrate up to that map of 65, you know, and try to go there. Can you utilize, I mean, not everybody always had pumps, right? In the field, we used to have to do the whole old school counting method. How precise do you have to be if you don't have an IV pump? I mean, can you?
It'd be very hard. I mean, you know, we're talking about a dosage variant between 2 and 10 mics per kilo, and being able to nail that down is really the only way that we know what we're doing to this person, right? Because of those three levels you were talking about. And if we even so much are, you know, 1 or 2 mics off, like, it doesn't seem like that big of a deal, but it is in terms of what it's doing to the body and how it's working. And so it'd be a very difficult thing, which, you know, again, leads me back to Levophed.
Yeah.
Right? Because Levophed is, you know, instead of saying, oh, this dose does this and this dose does this, it's start from the bottom and work your way up till it works. And so it's a little bit easier to manage. And if it is a little bit off here or there, we still know what it's doing to that person.
You know, ironically, when I was flying patients, and even when I was still on the ground, I remember taking a transfer out of the hospital, and the patient was intubated. They were sedating the patient with a Versed drip, and then chasing it with a Levophed drip because their pressure was in the jumps. And I'm like, why don't we just stop the Versed and give a ketamine drip and fix the problem that way, instead of, hey, we're causing this patient to be hypotensive, so now we're going to fix that by giving Levophed and putting this Band-Aid over it. Like, it makes no sense. And I had to question and ask them, and they were just, doctor's orders. But, you know, sometimes it's about knowing why your medications are doing what they're doing and the outcomes that we're getting as a result. Why are we giving more to this patient that doesn't really need more? We have other options out there.
I mean, you just watch for that rebound hypertension too when that Versed gets stopped as well.
Yeah.
And just monitoring your treatments like that, we could do a lot of harm with the medications that we have on our ambulance. And I think that probably the reason that we see medications starting to go away is the choice paralysis that we get.
Yeah.
Which one are we going to give? Let's just keep it to epinephrine and norepinephrine, right? Heart rate too low, epi. Heart rate's fine, norepi. And just keep it simple like that, because in the pre-hospital setting, we're talking about transports that are generally less than an hour. And we can manage our patient for less than an hour.
Yes. But on the other end of the spectrum, those medications, epi and norepi, don't have dopamine principles.
Right.
So there's still a time and a place, right?
Yeah, absolutely.
One of the other things to consider when we're talking about dopamine is, and one of the reasons why we have moved more towards hey, let's just manage this guy for the 15 or 20 minutes or hopefully less than an hour that we're with them, is also because there are a lot of contraindications for dopamine. Mm-hmm. There are a lot of things that dopamine interacts with that'll interact with it actually. I'm seeing here. Sorry, Tyler, I'm stealing your NIH.
That's okay.
Stuff, but it's talking about here that the conditions that you don't want to give dopamine may include like ventricular arrhythmias, tachycardias, blood vessel blockage, low blood oxygen content, decreased blood volume, acidosis, adrenal gland problems, and we just keep going on and on. Mm-hmm. It's talking about that really if you're going to give dopamine in somebody that takes an MAOI. Now I know MAOIs are not really widely used anymore, but every now and again you'll find somebody on it. You actually have to use a 1/10 of the usual dose mm-hmm. on those patients to achieve the same effects. And then further, it goes on to talk about some seizure medications that may cause way more hypotension that'll actually cause hypotension just because of the interaction. Then on the other hand, tricyclic antidepressants may cause the absolute opposite effect, where we're starting at 2 and we're getting these crazy results of 180, 190 systolic blood pressures, and we're just on 2 of dopamine. Yeah. And and there's all kinds of, there's a few other even like with oxytocin, it's talking about it can lead to like chronic hypertension and then even increased possibilities for CVAs. Yeah. So as we study these things and we become more aware of that, it's a good thing to know. But I think, one of the big reasons why dopamine is falling off is because of a lot of these things that we're learning about it. Now, it doesn't mean that here in like 2 or 3 years, we're all going to look at norepinephrine and be like, whoops. Yeah. And something better is going to come along. It's just that's where we're just kind of at right now.
Yeah.
And dopamine's very interesting, and just looking at its mechanism of action on the NIH website, it is literally 2 scrolls worth of information, if that makes sense to you guys. There's a lot that goes into how this drug actually works, and just to go off of Adam's point with the adverse effects or potential adverse effects, is it acts on a lot of things. So.
Well, I think it's because a lot of, when we talk about these vasopressors, they're all neurotransmitters in some sort, and they all have activations. And we talk about neurotransmitters, we're talking about our central nervous system and, all factors there. So they play an important role in our stability of hemodynamic stability. Do y'all have anything else you want to add as far as these vasopressors go?
Really, it's one of those things that you need to have familiarity with. You need to be cautious with them because a lot of bad things can happen. and you have to be foundationally secure in what exactly you are doing to your patient when you start reaching for these things.
Yeah, you still have to give your volume and make sure that you're ruling out the possibility of hypovolemic shock being the reason behind why we have what we have going on. And that's the number one key thing before we jump into saying this is a cardiogenic problem and we are going to treat it with this as such. This is the reason why.
Yeah, I'm glad you brought that up, honestly, because we don't just show up and find somebody hypotensive and say dopamine.
Yeah.
Or Levophed or whatever. We should not be necessarily walking into a situation thinking the first thing I want to do is start slinging Levophed or start hanging epidrips or whatever. Although, can be kind of fun, right?
Yeah,
every now and again.
But we're looking more at like our critical care paramedics
Correct.
at this point. It is not something that the everyday paramedic may get an option to do. And even when we're building our scenarios, we're looking at that is the end all be all of our patients at that critical thinking of, okay, I have done all of these steps. This is still not changing the outcome. Let's give it this one last go.
Yeah. And that just reminds me, before we begin to initiate some of these pressors, we should obviously try some fluids first.
Yep.
And even if the fluids aren't working, it'll give us a little bit of a volume boost for those pressors to actually help take effect.
Yep. And this is not one of those things where you just check your patient off every 10, 15 minutes. We have got to be proficiently setting our timer on our monitor and watching that blood pressure. No greater than 5 minutes, just making sure that we are proficiently checking over these patients.
Yeah, almost all of these drugs have a very similar half-life, ranging from 5 to 2 minutes. So that's what I would set my monitor to. Take a blood pressure every 3-5 minutes, whatever you might feel is appropriate, so that you can actually monitor to see if that pressure is still, infusing, or if potentially there is some kind of cutoff somewhere where there's an infiltration or what have you.
Yeah,
Absolutely.
any time you're going to be messing with anything, up or down, heart rate, blood pressure, whatever, you need to be checking on that because things can go wrong.
So we've said it several times, checking an automatic blood pressure, but don't be afraid to whip out your manual blood pressure cuff and get a good manual blood pressure. Just to back up what your monitor is telling you, but also in our patients that might have an aortic dissection that we didn't know about, check the blood pressure on the right arm, the left arm, and sometimes the legs too. I would advocate for the legs as well, because you might have an aortic dissection that's putting pressure on those brachial arteries, and both arms have low blood pressure, and we're just slamming norepi into them. And their actual blood pressure, their heart is just hammering away and increasing that dissection. So check in several places just to be careful and secure and confident that you're actually doing the right thing for your patient.
Absolutely. Do y'all have anything else you want to add?
I think that sums it up.
All right, well, that's a wrap on this episode of the Weatherford College EMS podcast. Big thanks for tuning in as we kicked off this section of vasopressors, a topic that can feel intimidating, but we promise it gets clearer with every call and every repetition. From Tyler, the NIH man, and Adam, the historian, myself as the field-tested perspective, we're here to guide you through it every step of the way. Stay curious, ask questions, and never stop connecting the dots between meds, the pathophysiology, and the patient. Until next time, stay safe, stay smart, and don't forget, it's not about just knowing the drugs, it's about knowing what they do and why they do that. Have a great day, everyone.